Mini implants is a dying solution, and thank goodness for that. Let me explain. Dental implants are typically described as being mini implants if the diameter of the implant is smaller than 3 millimeters. Okay, just as a general rule, that's what people say. And the concept is that perhaps you have a patient who doesn't have a lot of bone. And what you want to do is you want to use a very tiny implant, something smaller than 3 millimeters. That way you can get into the space. That in itself makes a little bit of sense, right? That makes sense in itself. The problem is it's an engineering problem. And let me explain what I mean by that. If you have an implant and it has a certain diameter, as the diameter of that implant gets larger, the strength of that implant gets higher. And it's not linear, it's exponential. So if you have a 4 millimeter implant and you have a 6 millimeter implant, a 6 millimeter implant is twice the strength of a 4 millimeter implant. Okay, so this is something I tell people all the time. They go, well, I didn't have the right size implant, so I just put a 4 millimeter implant in a molar. And I'm like, that is not in the patient's best interest. Why? Well, the molar has the highest bite forces, and you just put an implant that's half as strong in there because you didn't have a proper 6 millimeter implant. What you should do is reappoint the patient, procure the proper implant, and put the proper implant in, okay? So it's pretty simple on how you should behave and how you should proceed. But the problem is many dentists aren't trained in the biomechanical aspect, so they don't know this. So let me give it to you one more time. A 4 millimeter implant is twice, or a 6 millimeter implant rather, is twice the strength of a 4 millimeter implant. So there's a big difference. Well, when you drop down below 3 millimeters, that implant is so very tiny. It's like a tiny branch. What breaks easier, a tiny branch or a big branch, right? A tiny branch breaks easy. So it's so very, very thin that it's likely going to break under cyclic fatigue. Well, what's cyclic fatigue? Well, it's when you load something over and over again. Well, how do we chew? We load our implant over and over again. Every time we bite down, we load the implant over and over again. So we're putting our implant solution, whatever it is, into cyclic fatigue every time the teeth come in contact, every time that we chew food. So we have to make sure that we design our implants to be resistant to this nature. And this is why 3M, which owned 78% of the market share, one day wrote a letter and said, we're out. They just stopped making mini implants. 3M, a reputable company, cold turkey, stopped making mini implants one day, just stopped. And the reason they did that, I suspect, is that they knew what the failure rates were and they saw a class action suit coming their way in the future. Because it's math, guys. It's really difficult to sit in front of a jury of your peers and some engineer put up some mathematics that says this implant is extremely weak, and yet you continue to produce it, yet you continue to put it in people's mouths, and they had a lot of complications. So in general, if you've been doing implants for a while, the general trend in implants is that the mini implants have started to go away. The problem is there's always a small contingency of people that circle back around and pick up on these old ideas and they try to promote them again. I don't know why, but they come back up. So we've seen a little resurgence in people asking, well, what about mini implants? I saw that I could go to this course in the Caribbean and learn about mini implants. Go to the course in the Caribbean, have a good time, but don't place mini implants, okay? They're really, really dangerous. So how should you perform implants if the patient doesn't have a lot of quality of bone? Well, the answer is simple. Grow the bone. Grow the bone. So do a ridge augmentation procedure and grow the bone. And then in addition to that, I would argue that in fact, except for 3 patients in my career, I've been able to place regular implants on everyone. Everyone who is a candidate for All on X, I've been able to place regular size implants on all of them except for 3. Those 3 people were missing their teeth at age 19 or 20, and they were now 60 and 70 years old. So they were very, very atrophic. Those people, they needed to go for dramatic ridge augmentations. They were going to have cranial grafts or iliac crest grafts. They're going to have grafts in the hospital under OMFS to really grow some bone, right? They were a candidate for no bone. They weren't even a candidate for remote anchorage, okay? They had no bone, okay? But other than those 3, Every single other patient I've ever seen, ever, was a candidate for regular size implants. And so people say, well, what about the people who don't have enough bone? You're not looking. What I tell you is that you're not looking. And by whatever you do not look in someone's mouth and go, yeah, you're not a candidate. Your eye cannot determine that. Your brain and your eyes cannot determine that with vision. The only way for you to determine whether a person is a candidate or not a candidate for implant is through three-dimensional planning. You must scan them, you must put it in a software, and then virtually do the surgery. That's where you go, this patient's been told 3 times that they're not a candidate for implants. And you look and you go, Mrs. Smith, I could do implants tomorrow on you. Mrs. Smith starts to cry. At first, she's shocked. Then after a moment of shock, then she starts to cry because she's been told multiple times in her life she's not a candidate. Because people are looking in the mouth and going, yeah, I don't see a lot of bone there. Well, sure, you don't see a lot of bone there. But when you go to the radiograph, you go, oh, there's plenty of bone there. You have to go to three-dimensional planning in order to be good at determining whether or not someone is a candidate for implants. So the real need for these mini implants, it's not really there. It's a risk factor, and there's almost always plenty of bone. So in my practice, I have never needed a mini implant. I don't suspect I ever will need a mini implant, and there's some really sound reasons for that. So hopefully that helps. This has been another episode of Implants Made Simple. I'm Dr. Robert Stanley, the Smile Engineer. If you've enjoyed this video, please give us a follow. We'll see you on the next video.